Good evening.
Good
Uh,
evening to you.
Thank you,
Good evening.
Yek. And my name is George Gibor. I'm the General Secretary, Kenya Union of Clinical Officers. Allow me say welcome all participants and also the panelists. I think this is a good juncture for us to interrogate what is before us. Thank you.
Karibu sana. So thank you so much. Allow me to invite the chairman to introduce himself and take us through the bill. Thank you. Chairman Washira.
Yes, thank you. Thanks a lot, Mayek, Mary Boniface, and all the panelists. Somebody is talking? I hope you can hear me.
Very well, Chair. Proceed.
Thank you. So mine is to take all of us through the bill. I understand there are people who may not have seen it. So the bill is titled the Draft Quality Healthcare and Patient Safety Bill 2025. We proceed. Let us go to the main content. Good. Can you put it on presentation mode, like full screen? I can also share from my side if it's a problem, Nelson. Nelson,
I think there's an issue on my side.
let me share from my side.
Okay.
Yeah. Confirm that you can see that.
Yes, we can, Chair.
Okay, if you can that, let's proceed. I understand that today is Friday, and whatever Duba has said, but I want to request that I think the numbers, don't mind much about the numbers. The most important thing is that especially the leaders do understand so that we can have a meaningful conversation. So this is the draft quality healthcare and patient safety bill 2025. And let's just go to the preliminary is important. So this is an act of parliament to give effect to Article 43(1)(a) of the Constitution to provide for the responsibility of the national and county governments in the realization of quality of healthcare for patients, to provide for the establishment, powers, and functions of the Quality Healthcare and Patient Safety Authority, registration, licensing, and accreditation of health facilities, to set and provide for implementation of standards for quality of healthcare and for connected purposes. So part one is basically about the definitions, which I think we may not really dwell on. Let's go to the subjects matter. And I think one of the things that we need to look at is we need to note that when we are talking about the patient's rights, they are also contained in the Health Act. The Health Act of 2017. And of course, the CAP 242, that is the Public Health Act, about the standards that should be maintained within the health facilities. We have the right to information, that is number 10, and you can see that still it is in the Health Act. That is why it says notwithstanding Section 8 of the Health Act, because the patient's rights have been provided there. Then we have the patient's rights and safety, the same in the Health Act. The roles of the county governments is provided in 6. Am I going back? Sorry.
It's okay, Chair. You are doing well so far.
I think I was in number 10. We have the right to information and decision making in the Health Act. Then 11, Section 11 is about the patient's right to be heard. We have right to informed consent, which is still available in the Health Act. 13 is still on the right, and 14, the right to effective and timely care. The right to safe processes is number 15, that is Section 15. Right to safe and quality health products and technologies, number 16. Right to dignity and equity in Section 17. And then the Patient's Right Charter in 18. Yeah, so about the facilities, this is usually provided under the Public Health Act. It has also been brought here. The duty to uphold quality of care. Then 21, you have evidence-based practice. And this is basically, they are talking about adherence to clinical guidelines based on scientific evidence, including protocols. And the Cabinet Secretary, on the recommendation of the Director General, will develop and publish guidelines from time to time. Then safety and risk management is Section 22, where they are talking about IPC measures. They are talking about the safe use, storage, and administration of the health products and technologies, and also to report adverse medical and public health events. This is also found in the, I think, in the Pharmacies and Pharmacies Act. So then we have the implementation of procedures for detecting, analyzing, and reducing health risks and adverse events. And this basically, when you're talking about technologies, is usually it was in the Pharmacies Act. We have the quality improvement under Section 23. And here, the Cabinet Secretary is now tasked to develop quality improvement framework for health facilities. That is set benchmarks for patient satisfaction, clinical outcomes, and service efficiency. Include specific targets for reducing disparities in access, treatment, and outcomes across geographic, socioeconomic, and special needs demographics. Reflect the levels of care and resource availability, as well as incorporate timelines for implementation and review. And then every health facility is to develop and implement a quality improvement program that monitors key performance indicators, analyzes all data to address service gaps, prioritizing maternal health care, primary health care, maternal mental health, and emergency medical care, and also report progress to the authorities each year. Every health facility also to implement a structured quality assurance program, including clinical audits, patient feedback, and mechanism, and compliance with quality improvement standards, which shall form the basis of health facility accreditation performance assessment, that is the continuous inspection for quality, and access to the social health insurance fund. That is very important to note. So the authority shall also monitor the implementation of the quality improvement framework by the health facilities. Then 24, we have training and competence, where then every employer in terms of county and national must verify the qualifications and licensure of its workers and provide periodic training on patient safety, clinical guidelines, and quality improvement. Then we have professional indemnity. This was also in the different acts. I know the medical practitioners and dentists had one, the nurses had also, and also the clinical officers had this indemnity. Now it's being deleted and brought here. Then to verify and ensure that all its employees are contracted providers, they are covered with an indemnity. So 26 is about the duty to provide the that is about the safety and the patient rights. So then we have part 3, which is about the administration of the authority. So it establishes the Quality Healthcare and Patient Safety Authority, which shall be a body corporate. Then we go to the function. It's supposed to regulate and guide the development of health facilities infrastructure, register, license, and accredit health facilities. So number A was with the Public Health Act. Then number B was in different acts: Clinic Officers Act, Nurses Act, Doctors Act, physiotherapist, lab, and pharmacy. Regulate the conduct of health facilities was also in those acts. Inspect health facilities for compliance with the quality of healthcare standards. This was also there, and also together with the KUCOEngage, and undertake or cause to be undertaken regular inspections, monitoring and evaluation of health facilities to ensure compliance with the provisions of the Act. F is to establish and implement a system of accreditation of health facilities for quality of healthcare. G is accredit health facilities for purposes of empanelment and contracting under Section 33 and 34 of SHE Act. It is enforcing compliance with quality of healthcare standards. I promote public awareness on quality of healthcare, including on patient rights. Maintain a register of registered, licensed, and accredited health facilities. Build capacity on matters related to quality of healthcare. Inspect and accredit health facilities for purposes of internship and training. Provide policy advice and make recommendations to the CS on matters related to quality of healthcare, and advise the Cabinet Secretary and county governments on the standards of quality of healthcare for health facilities. And lastly, perform such other functions as may be prescribed by any other written law or as necessary for the promotion of the objects of these acts. So those are the functions. And of course, we have the powers. They have the power to enter, inspect, and search any health facility. So now we come to the powers. I think you can go through them. They will also be able to levy the charges. Of course, they introduce charges for that. And now we go to who sits in this authority. So the management of the authority shall vest in a board of directors, and this will consist of a chairperson who will be appointed by the president, the PS in the ministry responsible for healthcare standards or a representative who is designated in writing, the PS for National Treasury or their representative, the DG, one person appointed by the Cabinet Secretary not being a governor, nominated by the COG, with knowledge in matters health, quality management, and quality improvement. 2 persons appointed by the CS, not being public officers, nominated by the Consortium of Healthcare Providers and a Patients Association in Kenya. Then 1 person appointed by the Cabinet Secretary with expertise in quality healthcare for patients, and the Chief Executive Officer, who shall be an ex officio member of the board. I think you note that there is consideration for the health providers in terms of the facilities. But then what about, though the health providers may mean both the health facility and the practitioners, but there needs to be representation for both the practitioners and also the health facilities, if that was to be. So the appointment of the chairperson and members under WANI, that is the nominated from the COG, F, the 2 from the Consortium and Patient Association, and G, the one with expertise on quality healthcare for patients, shall have to be gazetted. And the qualifications for the chairperson: a citizen who holds a bachelor's degree in healthcare-related fields from a university recognized in Kenya, has a professional knowledge and experience of at least 15 years, health governance, health administration, public policy, or other related fields, served in a senior management level for a period of at least 10 years, and is in good standing with the relevant regulatory body, meets the requirement of Chapter 6 of the Constitution. So a person shall qualify to be a member of the boards if they have a BSc, they are Kenyans, at least 10 years of experience, matters of finance, social sciences, health administration and management, or quality management and improvement, and meets requirements of Chapter 6. So they shall hold office for a period of 3 years. And the members appointed under Section 31B, yes. So 31B, not that 1B, that is the principal secretary. 31B, C and D shall hold office during the tenure of office unless removed from office by the appointing authority, because those are the appointees of the president. So the other members, the chairperson shall cease, a person shall cease to be a chairperson of the board where that person is unable to perform the functions, otherwise unable or unfit to discharge his or her duties, or is adjudged bankrupt, convicted of an offense that of course they'll go in for more than 6 months, absent from 3 consecutive meetings of the board without lawful cause, resigns by notice in writing to the appointing authority, dies or is removed in accordance with the provision of the Constitution or any other written law. So then we have the committees of the boards in their discretion, and they can also be able to opt into the committee other members.
Excuse me, Chairman.
Yes.
A concern from members. I'm seeing members are requesting you take us through a summary, and then maybe you highlight the key areas so that the document
Okay.
interrogate individually later.
That's okay. So basically, I think we needed to note the Constitution, and then we needed to note the functions. You realize that the functions, most of them are being hived from other regulatory bodies. Most of the content here is also hived from the Health Act and the Public Health Officers Act. So what I'll do, I'll just skip probably the parts that may not be necessary, and probably go to where they are deleting. And whenever you need to do a medical camp, you have them to register with the authority. So I think I've just got to
I think, Chair, so far.
Yes.
I think so far, I think you have explained things with a lot of clarity.
Yeah.
And I think you can just summarize for the interest of time, because I think we have captured the contentious, especially the issue of establishment of the authority.
Yes.
The other places can be even in can be amendment in the Health Act 2017. Instead of
that is
establishing
where I
the
want to
authority.
go to. I think the most important, especially for this forum, is about now these consequential amendments to other acts. So Section 2 of the Health Act will be amended, and that is about the definitions mostly, that in the preliminaries. But then Section 14 of the Health Act, which will also be amended in Section 5, which provided where a health facility fails to resolve a complaint to the standard, to the satisfaction of the complainant, the Quality Healthcare and Patient Safety Authority established under Quality Healthcare and Patient Safety Act shall take the necessary action. So they are deleting subsection 5 and substituting with this. They're also deleting section 48. Nelson, where is the one that had the deleted sections, what they provided?
The one I shared last, let me share with you.
This should be the one. Okay, I think I can give a summary. Let me just give a summary. So they are to amend the Health Act because, as we saw, most of the things, especially about the rights, are contained in the Health Act. So there will be substantive amendments to the Health Act, and including the KUCOEngage. The KUCOEngage, the other one, of course, other than the Health Act, will be the Pharmacy and Poisons Board. Wherever we saw about the quality of the products was provided in the Pharmacy and Poisons Act. That will also be amended. So it is important that you look at the specific sections, especially who are those who are from the Pharmacy and Poisons Boards or the Pharmacy and Poisons profession. Yeah, we also have, that is CAP 244. We also have the CAP 246, the HIV and AIDS Prevention and Control Act is also being amended. We have CAP 253, that is the Medical Practitioners and Dentists Act, being amended, of course, in the areas providing for registration, licensure, and accreditation of facilities, and also issues to do with the professional indemnity. The same continues. Then we have the CAP 253. This is the Medical Laboratory and Technicians and Technologists Act. Of course, the same on the registration, licensure, and accreditation of the labs. We have the 253, CAP 253C is the Counselors and Psychologists Act. We have CAP 253D is the Physiotherapist Act, because they were also registering and also inspecting facilities. We have the Clinical Officers Act. 253E, previously 20 of 2017, also on the registration, licensure, accreditation of health facilities, and professional indemnity. Then from that one, now we have the Social Health Insurance Act. There is the dispute resolution tribunal is being deleted because there is that replacement under the new proposed act. And I think basically those are the consequential amendments. I think for me to just, the highlights from this is that the draft quality healthcare and patient safety bill, there is a lot of replication of other acts. It is looking like an omnibus that is supposed to come and hive many sections of other acts, consolidate them into one bill. But then also, the other things that it does, it takes the responsibility for facilities from the regulators and it takes them to one authority. Of importance to note is especially that now it will be doing the three things that are important for the quality of healthcare. Actually, four things. One is to ensure that they're having the right healthcare workers who are licensed. Number two is to register. Number three is to license, and number four is to accredit. This noting that the biggest problem that we have been having is where you have a facility that is level 2 but is allocated level 3. With the problem being that the person who registers, the institution that registers is also the institution that licenses and is also the institution that accredits. And I think we had proposed in the amendment bill that we had proposed to Parliament on the Health Act that the way to cure that is to improve on the quality assurance mechanism by having the person or the institution that registers and licenses different from the one that accredits for the purposes of insurances. So that is one. Number two, we can see some of the issues, some of the functions that are being taken from the regulatory bodies to the office of the DG. Notably, in this act, the scope of practice, which has been the mandate of the professional regulatory bodies, is being taken from a board where we were having 11 people to sit and consider, and now it is being taken to the DG. We recommend to the CS to be able to do the same. And the question begs, which is better in terms of quality? Is it a council with about 11 members drawn from educational background and regulatory background, or is it one office, the office of the DG? I think those are things that we need to ponder on. And basically those, and I think the panelists can be able to take from there and take us through the other things in the bill so that later we can come back and agree whether it's a hit or miss and what we need to do about it. Thanks a lot, and back to you, Mayek and Mary.
Okay, thank you, Chairman. It's still a contentious issue that we need to discuss, interrogate it, and dissect it very well. I know we are having our panelists, and I want us to make it a discussion so that we don't get bored along the way or our members get bored. Thank you so much for that elaboration. I'm seeing a hand that is raised. Okay, yes, let me pick your question, Bon.
Yes, thank you very much. Thank you very much, Chair, for trying to elaborate the issue at hand, which actually affect the clinician. My request is that for the sake of time and also for the sake of concentration, I request that if we can actually summarize, we don't go deep. Actually, you could have actually come with the summarized note so that through there, you are the lead. You are our eye. What you say, we tend to agree with.
Mr.
So
Bond,
from there
Bond on this.
yes,
Bond on this, the reason we put it at this time is
yes,
because we don't want to be in a hurry. We want to comprehensively discuss.
Yes.
So we want the panelists to comprehensively discuss so that people can understand, and then we'll be able to make an informed decision. Because then
yes,
when we limit people, we may
yes.
not do what we are supposed to do.
So, Chair,
Yes,
can I make my
I was
point? Chair?
I was coming to that. Just a minute. I'm not. I was coming to that so that now the issue is the concentration, and also as much as we are saying that the leader to concentrate, but we also need members to come in and have that first-hand information. It's something we can spread, for example, the whole week rather than doing the entire of it for almost 4 hours. Human concentration is also a matter. Something that we need to put into consideration. Thank you very much.
So Chair, can I? Duba.
I want to make a comment, and mine will take a minute. This is
Excuse me,
Mubama.
Mr. Mugama, we are having an order we are following. Kindly just
Please, order. We are having moderators in the panel. Do not speak unless the moderator gives you the mic, and the moderators will be able to take us through, so that we are going to first start with the panelists. After the panelists is when we are going to have input from members. Thank you. Over to you, Maya.
Thank you. Chairman, I want to appreciate you for that. Okay, now there is this issue that we need all to understand the bill, and I'm happy because we are not only clinical officers in this call. We are having other health professionals who are also playing very key role in health. I want us to, as we discuss, as health professionals, are we safe with the bill, or we need to act? The second thing that we also what are the
moderator
and negatives of the bill? Yes, Duba, it is you that I want to call. So that we
thank you.
Discuss, please go through the concerns of the people. Thank you. Welcome, Duba.
Thank you so much. I really want to thank Wachira so much for having taken us through the entire bill, and I'm sure most of us have not gone through, but I really appreciate your effort that you have taken to personally go through the bill and highlight about the duplications in the bill. I would really like to say that some of the issues are necessary. Patient rights and safety, this can all be done in the amendments of Health Act 2017. We can amend our laws. Pharmacy and Poison Act, Cap 242, it can be reviewed to accommodate those issues. In fact, the patient rights and safety is already advocated for in the Health Act 2017. And the government of this country, the cabinet secretaries in Kakamega, due to austerity measures along the guideline of IMF, did say that most of the parastatals are not necessary. They want to qualize them because there's no fund allocated from this checker. We're in a kind of measure that we cannot create a new parastatal. And I think these are people who came together in a boardroom for purpose of selfish interest and created an authority. If you look through the patient rights and safety in this bill, it's okay. I have no problem with it. I have a problem with the establishment of authority who want to use up the powers of regulatory board. This authority, if it goes through, then it makes the regulatory board non-existential. They don't have to exist. And you see a board composing of almost 8 or 9 people subject to corruption. The way we have been inspecting our health facilities and oversighting is really is not easy to penetrate in terms of corruption because it is multidisciplinary. Now you bring a chair, and there's some few members here who can be able to license, inspect, monitor, and accredit. We are encouraged. We are Kenyans, and we know this is not acceptable. And because of time and other members would like to speak, what I would like to say is that there are calendars, the timeline for these people to go out into the counties, and we should reject in totality. We have the numbers. Let's inspect our facilities, accredit as multidisciplinary, has already highlighted in numerous acts. If anything want to be done, let's amend CAP 242, let's amend the Pharmacy and Poison Act, let's amend Health Act 2017. So in my view, we should not accept this. This is, in fact, corruption coming back in the health sector in the name of what they call this safety and quality health care and patient safety authority. Some people want to create an employment for themselves. Let's amend the existing laws. We have already said we are collapsing the existing parastatus. Why are we creating another parastatus when we have a debt that we cannot even be able to really take care of it? This is not acceptable. It is passed in Kakamega the other day that there's no need to create more parastatus. They're even collapsing the existing one. So what is the reason? What is the justification for us to create such a monster that takes away the function of the regulatory boards? Thank you.
Thank you so much, Dumba. I want to bring Brown Ashira to give us his views and also what he thinks about the bill. Brown Ashira?
Yes, thank you. I think I want to say I'm grateful. Thank you so much, Kuko, for really creating time so that we can be able to dissect and maybe understand really what is going on in this country. I think we are in a country where you sleep today, you wake up tomorrow, you realize a lot is being changed here and then. I want to say that this country does not lack laws. We have enough laws. If you go to the clinical setup in this country, we have enough laws to govern clinical setup. If you go to the preventive setup, we have enough laws that is supposed to take care of the preventive setup in this country. And I want to say this for free, that it is high time that healthcare workers in this country unite. I think if we are not careful, we might go, we are likely to be taken for granted. Health is actually going to dogs in this country. We need to get united right from clinical officers to public health officers to lab, to nutritionists, to all the nurses and everybody, so that we can be able to agree that every law that is passed in this country must address our problem. I think we have a problem because if you go through the entire act, I want to say as a public health professional, because I'm a PHO. In this country, we have the Public Health Act, we have the Food, Drugs and Chemical Substances Act, we have the Pharmacists Act, we have the Clinical Officers Act, all the Nurses Act, we have all those acts in place. I think, to the best of my knowledge, the best thing would have been to look at those acts. What are they lacking? Some of those acts are as old as, I want to give an example of a public act. It was first enacted in September 1921. Actually, it's the grandfather of all the acts in this country. It was first in 1921. It talks about issues to do with the Central Board of Health. We needed to make sure that we look at the ways on how can we be able to strengthen the existing acts instead of bringing in the new acts that are aimed at duplicating the roles of different professionals in this country. And I wanted to say, we've gone through the acts. I think we'll be giving our recommendation and input, particularly on different sections. Section 61 requires accreditation requirements. We are talking about a lot of Section 77 on qualification of inspector, Section 22, Section 76, Section 23, and if you look at that act, then it's a question of idle people sitting together somewhere in affairs, idle people sponsoring people in the parliament to push through some things, some bills which are there to remember. We were almost boxed. You remember when the president said that when the regulatory bodies were removed, there was no money to fund regulatory bodies, and some regulatory bodies they were denied some exchequer. It was a deliberate move to kill other cadres in this country, and therefore it's important. And I want to request the chairperson Peterson Washira, because you've been on record. You actually you are the one now whom we rely on for guidance. But as other different unions, we're actually watching keenly, because ideally we need to say no to this bill. If this bill does not really, because if it does not seek to address anything, we need to tell those idle members of parliament and the people who are sitting in affairs that we have enough laws in this country. It's not that we do not have laws. We have enough laws. What we just need to do is to make sure that we amend. If the areas that we need to strengthen those laws so that those laws speak to life, to what is actually going on. So, as Public Health Union, I think as Kenyan Environmental Health and Public Protection Union, we actually objecting to the proposed bill, and we'll give our justification why we are saying no, because we have gone through the bill and we feel that we have been disadvantaged in a greater way, because PHOs do. If you look at before any health facility is registered, they begin with a public health clearance and inspection report. And we're talking about us inspection from the public health. We are talking about the structural condition of the building. We are talking about issues to do with drainage. We're talking about, it's not about health, ventilation and lighting. There are a lot of things that comes with that inspection. There's a reason why it was created or rather designed to be that way. So it is important that these guys understand that we are saying no to this bill, and if they go on and implement it, I think we need to have a nationwide strike. We need to have a nationwide protest that this country is killing health sector. We are busy duplicating roles. The other day they were saying that we don't have money. We are busy duplicating roles at the expense of a common mwananchi. What we need to ask is that the Bunge comes out strongly, strengthen the existing acts. We give life to the existing acts, and maybe if the areas we need to strengthen, let's strengthen so that we can be able, all of us, as healthcare professionals in this country, enjoy what we went to school to study. Let it not be forgotten that even in this call, we don't have doctors. I'm sorry to say this, you might misquote me. If you look at our senior brothers, the doctors, they are not on this call. Somebody will ask, why are they absent in this call? Maybe you never know what is going on. And therefore, we need to know what is their position, because you never know what is happening behind the scenes. We have a lot of cards behind the scenes. We have a lot of people trying to influence healthcare so that they can be able to muzzle other healthcare cadres in this country. So I want to really appreciate KUCO, and as Public Health Union, we want to go on record that we are opposed to this bill. We will oppose it. We will even, in fact, if possible, we'll do whatever we can so that we can be able to, all of us, speak in one language and say no, so that we can be able to safeguard. The other day as I finished, they created a monster institute called the Kenya National Public Health Institute. That institute, if you look at even its mandate, you wonder what is it supposed to address. And they took the function of my cadre. I think they mixed with the lab and other people, and we were brought together. If you look at even the leadership of that institute, it's purely medical doctors. You wonder what is an institute like KUCOEngage, which is supposed to address issues to do with outbreak and epidemics. What does a medical doctor go to do being a director general in that institute? Those are the issues we need to ask without even blinking an eye, and speak it categorically to this country, and speak it to the leadership of the president, and tell him that, look here, we cannot get it right when you're actually getting it wrong from the word go. So we are here, and we are supporting what is supposed to be done, and will be available just in case of anybody. Let it be one record that we are actually not supporting the bill. Thank you, and back to the session chair.
Thank you so much, Brown. I've seen some of our members have raised their hands. Allow me to bring one person who has raised their hands, then we will continue with the panelists. Huh? Nicholas Odipo. Nicholas Odipo, you raised your hand, but you're also part of the panelists.
He's a panelist.
Yes,
Okay.
yes, the panelist, and I've also seen you raised your hand.
So can I go ahead and or you give members?
Yeah, give your feedback and then maybe now what you had for this evening. Thank you.
Okay. Thank you very much. And thank you, KUCO, for organizing this forum and inviting us to this forum to come and discuss this critical issue, the Quality Healthcare and Patient Safety Bill. Now, I think in this country we need to be a bit serious with how we act. Because we have, just like Secretary Achira said, we have so many bills, we have so many acts, and these acts, nobody is supporting them to be implemented. Because the bill we have in front of us is not a bill that is going to cure a problem. This is a bill that somebody somewhere has just sat down, and most probably he has seen the billions that are coming in through SHA, and they want to control these billions. Now, I have questions that maybe I will ask as I make my presentation. Because if you look at the sections where this bill is talking about patient rights, it is in the Health Act 2017. The Health Act 2017 is now 7 years old, going to 8 years. Have we implemented the Health Act 2017? Since its enactment, have we gone and provided the right to the citizens that now we are coming up with a new bill with the aim of giving the patients their rights, and yet the rights are there in Health Act 2017, which is 7 years old. Number two, this bill is talking about a centralized registration of health facilities, centralized inspections, and accreditation. I'll talk on behalf of medical laboratory. Medical laboratory has been undergoing accreditation for close to 10 years now. And if you look around, we have so many labs that are now ISO certified, ISO 15369 or 389 certified. If this bill is coming to accredit facilities, why hasn't it been, why has the government not implemented this issue of accreditation? Because if you look at that, the act that forms the KENAS, there's an accreditation there. There's also this authority, the KHPOA, that was formed to coordinate inspections of the facilities and look at the quality of care that the facilities are giving. What has it been doing 7 years down the line? So that they come and tell us that now this one has not worked, let us come up with another one that is now going to use up the powers of the other acts or the regulators. Ladies and gentlemen, we need to think critically and look at issues critically. And we shouldn't allow people to manipulate the Kenyan citizens plus the professionals. Because if you take away the powers of inspection, the powers of registration and licensure of the facilities from the regulators, and then you ban them into an authority, and you have not even given a clear guideline on how this thing is going to happen. You just say that the authority will act. The authority will act on as to register and license facilities. Because as far as we are concerned, we know right what is currently happening is that we use our licenses to register labs, register the clinical medical centers and hospitals and so on and so forth. So what new thing is this act going to give us in this in providing that quality they are talking about? What we are saying is this, and we as medical lab we are going on record. We are opposing this bill, and what we want a stakeholder engagement, and we want every act that has been enacted in this country to be empowered to work for the benefits of the patient and the professionals. But coming up with fragmented acts and bills just to concentrate power and try to manage people, it is seriously wrong. In our case, we have been affected so much by all these things that are happening. Yeah. Right now, even validation of a test kit that we use in the labs, the ministry decided to take them to Pharmacy and Poisons Board. Recently, they came up with the NPHI that was supposed to remove medical lab from the mainstream ministry and put it in a saga. We are still fighting that. Now, they have come up with this bill to ensure that we are now clipped totally. So we are opposing this bill, and whoever is finding that there's something good, okay, fine, it might have something good, but the bad part of it outweighs the good part of it. Therefore, this bill becomes bad. We are not going to allow ourselves to be continued to be manipulated by agents who are not resting. This bill, it is not going to even provide that quality they're talking about. Let's not lie to ourselves. The other time they brought the KTTA, the Kenya Tissue and Transplant Authority. What happened later? Illegal kidney harvesting. And they came and said that now this is the authority that is going to regulate the tissue transplant. Yeah. Within 5-6 years, there's an outcry that people are harvesting kidneys illegally. So they come up with this one and try to confuse the public that they are going to offer quality healthcare. Let them implement fully the Health Act 2017. Let them implement our act, that is MLTT Act of 1999. Let them implement these other acts so that every profession be given a space to regulate themselves and also to regulate their practice and business. There's nothing that there's an authority that is going to come to help us regulate ourselves. We are lying to ourselves. I think I'll stop at there, moderator, and I'll come back later. Thank you very much.
Thank you so much, Mr. Odipo. Allow me to invite a lady. She had raised her hand. She's called Nyambura. Nyambura, are you still with us?
Yes,
Nyambura.
Thank you so much. Thank you, Kuko, for giving us this platform to express ourselves. I'm just so much concerned that I remember when we were presenting in the task force, they also raised a concern that every time these people find a gap, they try to come up with a bill that even it doesn't become implemented, all of it. Now we have another one. It's like they have been going around with us, knowing, for example, what public health looks into. For example, in section 46, they are clearly indicating about the layout and the specifications, but they have not indicated the specific people who should look into that. And general, this general thing that they keep saying a health professional, they very well place themselves in those positions to finish other cadres. Now, I was asking myself, do they want to go back to school to learn what other cadres can do so that they can be doing everything for themselves? I support everybody else that we all turn up and go against this bill. This is not the time that we always go silent and bills pass without our knowledge. If we all unite, we are going to win this war. Thank you, everyone.
Thank you so much, Nyambura. I'm loving the discussion. We are doing well. There's one panelist that I want to bring on board. I'm seeing so many hands have been raised. I'll be breaking so that we give also our panelists time to share with us what they had for tonight. Mr. Ondieki.
Thank you, Maye. I think today I decided to take a listening approach, but I want to talk about two things. One, just like Washira said, this act is going to bring a lot of confusion into the market. And number two, somebody asked what is the intention to take away self-regulation of private practice and all those inspections, then it leaves the regulatory bodies with practitioners. So what is coming up, it's to merge all these bodies and make an amorphous body that can regulate all of us except three bodies. I think they leave out nursing, they will leave out KMPDC, and they leave out Pharmacy and Poisons Board. The rest will be merged into one body. The bill is already in draft form. Now, for those of us currently doing SHA, the confusion is here. Yeah. They created, which acts as a monitor of social health authority. So whenever we have issues as facility owners or providers with challenges with seeing the clients and everything, for instance, you must ask the CEO of Digital Health Authority. So the CEO SHA must ask the CEO Digital Health Authority. So what are they creating here? They're trying to create another body that will come and gag all of us, and eventually it's dissolve all these regulatory bodies and form one body. And this is a habit that I think has been borrowed from what is the practice in East and Central Africa. If you go to Uganda, there's an Health Allied Workers Union, a regulatory body. If you go to Tanzania, if you go to Zambia, if you go to South Africa, we are the only country in Kenya where most of our regulatory bodies are self-regulating. So if you're not keen as practitioners and as professionals, this is the time for us to step forward and take this bull by the horn. Now there's a question that came in that we needed summary. Colleagues, it's very painful when an act of parliament has been put out there for you to read, then you pass the responsibility of reading, digesting, analyzing to your leaders. That is very dangerous. I'm very happy that we've read this bill. Personally, I've read it. Today I was doing my analysis of that bill, and I'm prepared to go for public participation when they come to Kisumu. And so I want to call all of us, 47 counties. Can we all leave everything where public participation is in your constituency, in your county? Leave those patients. Let's go and give our views. It's from those views that we can challenge this law anywhere in a court of law. And I can assure all of us, this is going to end at the Supreme Court. So in my view, it's a dangerous bill that we need to tackle, reach out to our all respective MPs, senators, lobby to the best of our capacity. That is my presentation as at now, but I'll be able to respond to any other questions that may come. Lastly,
Okay. Yes.
If you look at all these regulatory bodies, they have somebody called Consumer Federation, representing the consumer, who is the patient. So if they're talking about patient care and safety, the regulatory themselves have allowed a Consumer Federation to bring in somebody to come and protect the consumer of our services. What is this Consumer Federation has done? Where has it failed? These are the questions we need to pose. Can we be given data that they have failed? There are these complaints. And I like the presentation from my colleague Kunumle, that let us ask hard questions. KHPO has been there for the last 7 years. What has it achieved? They literally refused to operationalize the act. They crippled it. Now we are creating another body. So colleagues, let us stand up. Let us leave everything from 23rd to 27th, converge where this bill is being discussed. Anything else on social media will not help us. That's my presentation.
Okay, thank you so much.
Just as I joined the moderator, that should be our clarion call.
Yeah.
We have to be in that, we have to leave everything at the facility and participate.
Okay.
Thank you, the presenter. That should be our clarion call.
Maybe you regulate so that we reduce the time. For those who are in the panelists, they make just a short remark so that we allow questions. That's where the interaction comes from.
Okay.
If you may.
Thank you so much. Thank you, Gibore. Thank you, Duba. Thank you, Ndieki. I know everybody will wish to give out their inputs, but because of time, maybe we need to redo another one so that at least we give people time to give their inputs. I want to hand over to my co-moderator, Mary Boniface, to take us through the second part of the session. Thank you so much. Mary?
Thank you so much, Mayet, for that. And thank you, the earlier contributors. And we have had quite clear, clear points to take home from this discussion. And one, it is clear that there is over legislation. And two, then what are we supposed to do as healthcare workers to ensure that we do not we do not get in the mix of all these over legislations, and more importantly, protect what we already have. So we have a few panelists who are yet to make their comments. And like we have said, let's be precise to the point so that we can open the discussion and we answer the questions as they come from our audience. So at this point, we welcome Matole Moses, the President KCUE, to make his comments. Mr. President, you can hear me.
Yes, Madam Treasurer Mary, I can hear you. One, I want to appreciate the insights which have already been given by the earlier presenters about this bill. Indeed, this draft bill is a bill which, if you look at the contents, if it is passed the way it is, then of course it is going to weaken, or rather not even enable our regulatory bodies to be able to do their functions. So I want to briefly give my insights about what most probably will happen if this bill is passed. Having gone through the bill, I want to share my insights. And I want to say that one of the things which most probably will happen is, if you look at the bill, especially on clause 27 and 28, where the bill is looking at establishing a quality healthcare and a patient safety authority. If you look at the mandate of this bill, then that means it will bring jurisdictional overlap and regulatory conflict, because we are all aware that our regulatory bodies regulate this profession. So if this bill comes into action, of course, they'll not be in a position to do what they've been doing. The number two concern on this bill is about the scope of practice and clinical protocols. If you look at this draft bill on clause 21 and 22, the authority and CS, through the Director General, are empowered to develop national clinical protocols and determine standards of care. So that means, of course, if it is given, if it is passed, the scope of practice and clinical protocols will basically be a mandate of the DG. And that is not where we want to be, because, of course, we have our own regulatory bodies which can do that mandate. The other concern on this bill is on disciplinary and accountability mechanisms. What the bill proposes, if you look on clause 19, 22, and 70, it introduces mandatory reporting of adverse events and institutional accountability systems, including penalties. It gives the authority powers to investigate, sanction, or revoke approvals from healthcare facilities and indirectly affect individual practitioners. So you can imagine, if the penalties are that hefty, what is going to happen to those in private practice and also those who will maybe be affected this bill and are working in a public health institution. The other concern on this bill is about basically, if you look at the council, the board, we see that most of those will be sitting in that board. The members who have actually joined here, most of us will not be sitting in that board. So there's lack of representation in the authority. So we really need to not allow this bill to go through, because basically the healthcare profession will be regulated by one cadre, and we don't want to go that direction. My fifth concern is on training, licensing, and accreditation overlap. The responsibility of training and accreditation is a responsibility of regulatory bodies. I'm here speaking on behalf of clinical officers in this country, and I want to say that we are all aware that the Clinical Officers Council is our regulator. So if this bill goes through, that means the regulation of our profession will now be under this authority. That is not where we want to go, and we should stand firm, give our input during the stakeholder engagements, and ensure that this bill does not go through. My last concern on this bill is increased reporting and compliance burden. If you look at the draft bill, it says on clause 19, 22, and 67, facilities must report adverse events, maintain quality data systems, and fill annual safety audits. So there are a lot of things that now this on matters of data that these facilities will have actually to, and we are not against it. But again, remember, if you not be able to do all this, that means most probably your facility will not answer. You'll be denied your license. So colleagues, as we await for the presentation, or rather for engaging the stakeholders, I want to call upon all clinical officers in this country, as we are looking at date 24. I think 24th will be starting at Nakuru. Let's come out. I know we as top leadership will be coming with a common memoranda where we'll be sharing to our colleagues, so that we can read all from a common position, so that when we go out there, we'll be sharing our concerns. So let's come out in good numbers and share these concerns, because this bill is draconian, and of course, it is going to weaken our regulatory bodies and it will deny us our autonomy and practice. Thank you, colleagues. That is what I wanted to share to the team.
Thank you, Moses, for your contribution. Please continue being in the call. We will have a question and answer session immediately after that, after this panel discussion. So then allow me to bring in the other two panelists. I would want to start with DS George Gibore, and then we finish with our beautiful colleague from KUNAD, Madam Lillian. So Gibore, please take over.
Okay, Mary, can you confirm whether you can hear me?
Loud and clear, please continue.
Very well. For purpose of time and also not repeating myself because I think I've heard a statement from other people, I want to just be precise on this issue. And before I make any statement, is clear that this document is advisorial. It does not add value to the service delivery, as it has been entitled as a quality healthcare and patient safety bill, which you think as the posture to present it is like a new inventory, which is not true. There is nothing new, as all of us are stating, is that most of the issues they are bringing here, they are just drawing from one document to another document, just some assaulting among the documents or other act of parliament that do exist, and therefore it doesn't really make sense at all. And you cannot understand if at all you are to answer the following questions, as I may answer without looking at specific, is that indeed, why are we allowing ourselves, the outsiders, to make a decision for us? And I have seen the KMPDC, as much as they might not be in this call, they are not happy. The nurses may be happy, I don't know, but I've seen as CEO, we are not happy. Medical laboratory, public health, among others, are not happy. And you can only sum it up that indeed we make it very easy for the employer to antagonize us because of our disintegration, because of how we have demonstrated disunity. We can only overcome these challenges that is before us by calling each other, coming together, uniting for purpose, for a cause, and defeat this monster that is being created here. How will you imagine that a bill taking away mandate from an institution, put it in an individual who have made statement publicly, even against other cadres, demeaning other cadres? And that's to mean that someone will be saying that the position of the Director General is an institution by itself. That's a lie. It's an individual who takes, actually there is an advert, an individual is interviewed, then takes office, and individually can make a decision and advise at that capacity through an appointment. And therefore, if you have someone who is very negative about others and they given responsibility to make a decision about them without consulting anywhere, I think that is where we start eroding, and we must stand against that. And it will be, what is then the problem with, if at all we have gone through this document, we ask ourselves, what is the problem with the bill? And every one of us have pointed out, who is the originator of this bill? Is it the Minister of Health, the state? Who is he? If at all we, the healthcare workers, are not happy and we are not the originator, so do we have bystanders who have observed very clearly and they are making maybe a kill out of this because they are establishing an institution where they want to go and sit themselves? What is indeed the driving force for this bill? What is the problem statement. I haven't seen the problem statement that indeed can drive us and rather make us that indeed we are addressing a solution, rather a problem that require attention to all Kenyan. And as I finish, I want to categorically say, as a union, we have gone through, perused through this document, and it stands to demean, or rather to demean our regulatory body, taking away its responsibility, and more specifically looking at the activity that normally give the council some resources. For instance, if you look at the facility regulations, that's where normally council gets some money. And once you take it away, you are actually denying them resources. But again, why separate facility from professional? It is like separating courts away from the judges and advocates, so that then the manager is different on this side and the other side. There have never been a question of quality in this country. We have a question, and the problem that we have is about lack of staff and matched funding, where we don't have enough funding. We have a lack of priority in terms of what needs to be done. And therefore, I think we need to correct ourselves and get what are the real issues. The government is missing a lot, and we feel that they are creating a problem where there is none, for them to confuse us that there is maybe some development that is ongoing in the health sector. I think the cost for healthcare is still so high, and that affects the quality of service. They should first address that. Lack of enough staff in our facilities deny Kenyan services. Those are the issues we need to see how they can be addressed, not this mimic where you are borrowing from this act of parliament and here, and then you come up with another act of parliament establishing a board or rather an authority where you want to create position for some few individuals. But I must say, this is just a smoke. There is fire coming, and we are well informed that there is a document that is being prepared by Treasury. It is more even dangerous, because we as a country have actually adhered, or rather embraced self-regulation, and that thing is, I don't know how it become like a thorn in the flesh in the government, because they're not happy about self-regulation. They want to put us together. Unfortunately, even those who have been pushing for the same, they are now crying for. So our unity can deter this. Our disunity will allow them to get this. You can see the kind of letters. I've seen very many letters today. Already the ministry is calling everyone to go and try to tell them why they're coming up with this. And we, the healthcare workers, have not been considered even to be the first priority. So let us have even tomorrow or the earliest time we can, let us issue a statement about this, so that at least even those who are starting to participate in this, in stakeholders' participation, know the position of the professional. Thank you.
Thank you so much, Gibore. Receive your claps from colleagues. That is quite well elaborate, and we will take that into consideration as we consider our way forward, because like you've asked, exactly what is our problem, and quality of care has never been an issue. We have so many other issues that are unaddressed, and even as we continue, so, you know, should we reject this bill partially or reject in totality? Let members be thinking that as they raise the questions. And now let's hear from Madam Lillian Momina. Lillian, kindly come in.
Thank you. Thank you, Mary, for that and for this opportunity. I want first to echo the statements of the previous speakers. So my name is Lilian Mumina, the National Treasurer of the Kenya Union of Nutritionists and Dietitians. And through the SG, as nutritionists, we are rejecting in totality, because as it has been said, it's clear that this is not a bill that is meant for the good work or something the good will. You know, the title of the bill or the heading of the bill, patient protection, they want to come out like they are looking out for people, they are looking out for the welfare of the countries, of the Kenyans. But in reality, it's just something that is coming in to overlap and to ensure that dominance in the health sector is maintained, which is quite unfortunate, because when you think about it, health is not, it's no longer, you know, sometimes they tell you that, you know, you need to borrow best practices globally. They will now compare, like I had one of our panelists talk about the way Uganda has like three major regulations for the major cadres, in quotes, and I quote, major cadres, and then they have clamped all the other healthcare workers together. Unfortunately, we don't need to borrow everything, because sometimes if we borrow things blindly, we become stupid. So as a country, we cannot afford to borrow such blind regulations. And as healthcare workers, as Gibora said, we are the custodians of health. So how are they just coming up with a bill, calling other people to engage? And they have not talked to the people who are going to own that bill. So it's quite unfortunate. And as a union, the nutritionists through the SG, we definitely reject in totality, as Boniface was asking. And I think moving forward, apart from lobbying, you know, because you see, this government has a strength of manipulation. They have learned the art of human manipulation and mass manipulation. So they might use the fact that they want to protect the bill. So a lot of awareness campaigns moving forward on why this bill is just a replica of what is exactly happening, of what we have in our laws, and what we need to actually strengthen and not just add. So maybe we can stage awareness campaigns to actually engage the masses, engage the people on why this is not just a bad decision, it's a terrible one for each and every healthcare worker in the country. So I think that's it, because we have had speakers who have talked a lot about the bill. They have actually dissected it. And yeah, we continue the discussions, and we appreciate KUCO for this as a union. So we are in total support, and we are definitely in for the briefing that the SG KUCO has actually called for. Mary, back to you.
Thank you, Lillian. We really appreciate your input. And of course, the fact that nutritionists have come out to add their voice about this bill. So, team, we are in this together as comrades, colleagues, and healthcare workers who are really the backbone of the health system in Kenya. I don't know whether our SG Chebi managed to join. Mr. Chebi, are you in the call? Joseph Chebi?
Maybe as you wait for him, I can add something.
Yes, our host, Mr. Chair, please come in.
Yeah, thank you, Mary. I think the other thing we need to know, Vincent, is that Vincent, please mute your mic. Or Nelson, you can mute him. So the other thing that we need to note is that the court has already made a decision in terms of the quality, who is responsible for quality. And in the judgment on the Health Act, when the Canaan and Pharmacy PSK went to court on the issues of discrimination, I remember then they actually wanted the judge to declare KH poor, that it is unconstitutional. But the judge took another route, and the judge interpreted KHPOA to be the ultimate body that is concerned or that takes care of the quality of health in Kenya. So once a court has determined anything or has interpreted a law, that becomes the interpretation that is known. And therefore, that means that we didn't need any other body for quality of care. The only thing we needed is to review KHPOA, and I think Ondieki Eric said it very well, that KHPOA has been there. The only thing that we needed is to amend the Health Act, give it more powers, give it more functions so that it addresses what we need, and then that would be covered. Yeah, that is what I wanted to add. Thank you, Mary.
Thank you, Chair. That is quite eye-opening, and I believe it will guide our members as they go to do participation in the various counties. Chebi? Joseph Chebi, are you in?
Yes, I'm in, Madam Mary Ponives, and
Thank
the
you,
top
Esther.
leadership. Yes.
Please go ahead and make your remarks.
Okay, thank you so much, leaders and fellow colleagues, for creating time to make contribution on this draconian bill. I know, and I've been very keen to follow on the discussion very well and the contributions from the members. It is very clear that it is something that may likely have a far-reaching effects, not only to the clinic officers, but also to other gathers. And the bill looks very attractive, even by the naming alone, that it is quality of care. But it is quite hidden with a pre-planned agenda in one way or another to actually take up the powers of our regulatory bodies and at least have them exercised somewhere by other people. And you can very well see when we went through this bill, it's obvious that some of these powers are reverted back to the Minister of Health, where you see a principal secretary being mentioned. It tells you exactly who will be calling the shots. As we continue analyzing this bill, and first, let's see how the Attorney General has managed to rename some of these acts of parliament. And surprisingly, these parliamentary acts came at different times. But as much as we are told that this is a rearrangement by the AG, but I think there's something that we were supposed to have been involved so that we also get to understand what it really means. Number two, when you exactly look at that bill well, let me not to mention quite a number of clauses, but it is very clear that people are quite interested with the management of facilities. And that one is very clear, that power of managing. And it's also coming to also managing the practice. So it's like it has its own intention that we really need to look beyond the quality of care bill. And then lastly, it is also coming also very clear that there is also something that is on the way. After this, I know there will be a bill that will bring in the merger, as my predecessor talked about, a practice practiced by other countries, even in East Africa, that they have a joint regulatory that has not performed in any way. If you go to Uganda and even these other countries, in fact, they are picking the best practices from us because theirs are not working. It is something which is quite amorphous, and we cannot go back to that that area. And we have also seen other laws, and probably also some people want to usurp a lot of powers, and some of them on some of these positions you see in the same bill. are some which already the courts have pronounced itself, and you still see coming through the back door. So, ladies and gentlemen, to me, all of us need to fully scrutinize the bill. Let's come up with a memo that we speak one language. Let us participate in this. We call it public participation. Public, it's us, and I would really want all the cadres to join hands and be present where this participation will happen. And as we come up, let us have a joint talk. And I know today, even while we were in Machakos as the leadership of clinical officers, all the organs, I think we are working, all of us, to come up with a memo, which should be actually jointly. Thank you for everyone who has made a contribution. Since the bill is something which is still new to all of us, I'm also very keen to listen from other members so that I can also add on what I already have in mind. And as we come up with a memo, but generally the memo we should be pointing to resisting against this quality of care bill. Thank you for the opportunity, Madam Boniface, and the leaders and fellow colleagues. I submit.
Thank you so much, Bona Secretary KCOA Joseph Tebi. We appreciate your input, and that is well taken into consideration. At this moment, please allow me to bring in the members. So our panelists do not leave. You're going to be answering the questions and bringing in your comments in between as members comment. And then immediately after that, we are going to have the final round of comments from the panelists, and then probably we leave it at there. So we have exactly 1 hour to the top of the hour. So kindly let's hold on and continue so that we finish together. For those who still have questions and do not want to raise them by way of speaking, kindly post them in the chat. We're going to read out them for you, and we're going to have that discussion. So to kick us off, please allow me have these two people whose hands have been up longest, and I would want to start with Gordon, then we move to Odwar and Vincent, then John Mutua. We can do four sets. I think that's a good number. So Gordon, please come in. Nelson, please give him the mic.
Thank you. I hope I'm audible.
Yes, you are. Go on.
Yes, thank you. I'll be very brief. Have listened to the panelists or leaders to confirm, because I also went through the bill and actually I was struggling to get what was the gap that this bill was coming to address, and it is clear that there is no gap, and policy should be hinged on addressing a gap. We are clear that there is no gap. That actually underscores why we need to come out in large numbers to participate and to justify why we do not need this bill to see the light of the day. Secondly, looking at the composition of the members, I know they read the qualifications, but not explicit whether all cadres will be given an opportunity. It is just left open so that it is subject to be abused by our other counterpart who will decide to dominate and edge the most majority of us, like you find other cadres at the majority. So we will actually be serving at their mercy. So with those two, I just want to encourage that, as our leaders have requested, we come out in large numbers and actually ask these fundamental issues and underscore why we do not want this bill to see the light of the day. Thank you, and over.
Thanks, Ms. Gordon, for making it sweet and short. The point, well observed. Odur Otieno, please come in. Odur Otieno, can you hear me? As we wait for him to come in, Vincent Koech, please go.
Good evening.
Good evening.
Good evening to you.
Good evening.
I'm Vincent Koech, a clinical officer. I may start by first opposing the draft bill. That my point of concern is if we allow this bill to go and see the light of the day, we are going to the bill seeks to interfere with the autonomy of the cadres in this country. Because myself as a clinical officer, if given an opportunity maybe to serve in that commission or authority, how will I have the capacity to regulate, to understand what happens in the public health, or either in the laboratory? I think it is prudent enough for every cadre to regulate itself, and let us whip all our members, all cadres, so that we come and oppose this draconian bill. Thank you very much.
Thank you so much for your input, Koech. Once you speak, please lower your hand. John Mutua.
Hello, Mary. Can I speak now?
Yes, you can.
Yes.
Go ahead.
Thank you, Mary, and thank you for the entire the leadership, KUCO. First of all, I think let me state that I'm a clinical officer, and as a clinical officer, my area of practice is patient safety and quality improvement. This is a space I've practiced in, I think, almost now 10 years now. And I would bring it to you. Yes, there was a gap. And this gap, I don't know how much time I have, but let me just bring it in a nutshell. I think for most of us we've seen NHIF, and there was a time we were asking ourselves, should NHIF and facilities? You go back, you realize there was a mismatch.
You're breaking or somewhere where you're stable, you're breaking.
Look, am I still breaking? I'm seated, I'm quite stable. And if you look at the global practice, the payer does not accredit health facilities, and the payer does not do inspections. So when you look at that kind of practice, you find that there are some gaps, the gaps that were there, that this bill is coming to cure. If you also look at the global practice all over, let's not restrict ourselves to East Africa. Let's look at the global practice. If you look at the global practice, the patient safety and quality improvement journey, you find that there are standalone oversight authorities, oversight systems for patient safety and quality improvement. And this practice divorces the professional from the process of care that happens in a health facility. And I would tell you that without fear of contradiction, whether you mention COC or you mention KMPDC, they are not in place to regulate, they are not equipped to even regulate the practice of healthcare in these facilities. Why am I saying this? If you look at regulations, for example, for COC, what we have COC, you look at the best practice is that we have competency around domains. And when you have competency around domains, you'll be speaking about patient care and clinical care. You'll be speaking about system-based care, the system-based care practices. You'll be speaking about quality improvement and practice improvement over time. You'll be speaking about organizational communication. It's about a 6 set of within that domain. And the same is applicable when you look at, the same is applicable when you're looking at now the practice of healthcare in the healthcare institution, the health facility. And I know from that, from the gaps that were there, you come to realize now, we tried to cure something, and that's why we came up with KUCOEngage. The KUCOEngage issue was not for health facilities, even though we were made to know, to think that it's about health facilities. They came up with a joint inspection checklist, which was a misnomer. From an expert point of view, that was a misnomer, because KUCOEngage, even by the name itself, is Kenya Health Professionals, the professional, not the health facility that provides the process of care. So KUCOEngage, even with its functions, does not bring that clarity in the practice of patient safety and quality improvement. So colleagues, I want us to divorce this bill from the professional and come back to the healthcare facility. And when you look at the healthcare facility, let me just give a small preview. Recently, we had here a mismatch of KMPDC accrediting facilities and SHA empaneling them directly. With this bill now, we are having one accreditation body that accredits facility, whether the health facility is run and managed by a CEO, or whether the health facility is run and managed by an EMO, the accrediting body is same, and the accreditation standards should be the same. And if you look at this, the reading in the bill, it says that, and this is the global practice, and I would even take you back to the aviation industry. The pilots don't say what happens in the airlines. And when there's an accident or a patient harm or an investigation to come, the pilots don't go to investigate. There is a standard body, the National Transport and Safety Board, very clear cut. And it's not led by pilots only. You'll have all manner of regulators inside it, all manner of people who practice, even the airline associations, you'll have them in there. So that's just by the side bit. So when you look at what we had recently, KMPDC running with accrediting facilities and SHA running on that, simply because they are the big brothers. So here the bill is saying we want one unit to accredit facilities. And how are they going to accredit facilities? In collaboration with the regulators who are there, the professionals and the experts. They are going to draw standards. And I heard my colleague say that as a clinical officer, you will not know what is required for a lab. When these people sit together, they collaborate, they develop the standards. But now, the professional regulators, COC, KMPDC, KMLGTB, do not come back now to superintend the application of these standards. Someone else does that. This is what the bill is coming to cure. And for those colleagues of ours who are in private practice, the bill is also speaking of one license. Here, we are speaking of one license in that if you are running a health facility based on the standards that are set and based on the requirements that are set, if you meet the requirements and the standard and you want to run your facilities with a laboratory inside it, you are not going to sign another license, pay for another license with KMLGTB. You are not going to pay for another separate license from PPB to run a pharmacy or run your pharmacy inside the facility. Oh, my colleagues, for anyone who is in the business of health practice, how beautiful is that? Let us not just speak and say, oh, we want to reject this. Let us separate the profession. So the profession as COC, and if you look at the act that this bill is going to amend, one of them being COC, it's just removing the issue around facility, health facility. But the profession, in terms of the training of the clinical officer, in terms of the internship of the clinical officer, in terms of the licensing of the clinical officer, in terms of the maintenance of competency for the clinical officer, of which even as we are speaking right now, KMPDC does not do it well. Even Clinical Officers Council does not do it well. Because when you look at maintenance of competency, it has like 6 domains. The only thing we keep on running about is CPDs, CPDs, and the rest. But going the full cycle of the 6 domain areas for competency maintenance, it's not happening. If you ask COC right now, among its clinical officers who are registered, how many of them are failing in practice? How many of them are on probation? How many of them are being taken through remedial actions? It is so wide and so broad. And even KMPDC itself is not able to provide that practice. When I hear my colleagues say that we've never had issues around quality and patient safety in this country, I wonder, simply because we always hear issues around patient safety and quality. Patient safety and quality. Patient harm incidences, when they come around in this country, KMPDC is not even able to sort out those things. Simply because the myth of self-regulation. KMPDC will come to shield its doctors and throw the nurse under the bus and throw the CEOs under the bus. And the global practice is that when there is a patient harm or incidence issues coming up, they are investigated into totality. They are not thrown to the parliament. You know what? The things we see in parliament, those are circus, those are shows, side shows. A recent example is with the issues of kidney transplant issues with Medicaid. You realize that something like as grave around patient safety and quality of care as that was happening in this country, and all the regulators are not able to come up. And even the expert team that the cabinet secretary put in place are not even able to agree on the report. That is a problem, my friends. That's a problem, my friends. And COC cannot cure that. KMPDC cannot cure that. Let's not lie to ourselves. KMPDC will not cure that. So I think, okay, I've been in this area for a very long time. I can talk till tomorrow, but let me hold it there and just tell you guys, yes, the bill, as someone who reads it and someone who's practiced here, it has its misses, and it has its hits. For example, one of its misses is that it has not clarified how to go about investigating a patient harm or incident of the magnitude of what we are seeing in Medicaid. That is a miss, something that needs to be strengthened. But let me ask you, my colleagues, even COC, with the number of healthcare facilities that they regulate, that they are registered under them, if you ask them today to give you data with regards to quality of care in those facilities, will they give you? No one publishes quality of care index in this country. The global practice is that annually, the way we have state of the nation, you need to have state of quality of care in this country. Publish an index, quality of care index, based on the practice areas within this country. In terms of, and when you see the bill has tracked a little bit of it in terms of monitoring outcomes of care and reporting and the rest. That's why that reporting is there. So my colleagues, as someone who's practiced in this space, let's take time and read this bill. There's something good, there's so much that we need to do, but we need to beef it up and make it compact. I rest my submission, my friends.
Thank you so much, Edward. It is so great for us to hear from the other side of the riverbank, because the majority of us here, we are on this other side, and that is quite eye-opening. I know it is a different opinion from what most people are expecting. But you can be told that by the emojis that were flowing. But again, that is quite important, and we cannot ignore it. We need to add that voice to, to our action as we go about how we're going to draft, whatever it is that we are memorandum with the amendments and then that we're going to do after this. So Oduor, I believe your voice will be quite critical in our further discussions, and I would like to kindly request you, drop me your number at the chat box. I'll reach out later and then we can have that discussion. Thank you so much. I would like us to hear from John Mutua, and then after John, we bring in Chris Onditi.
Thank you, Mary. This is John Mutua. I'm a clinical officer practicing in Machakos County, and I've really heard what Oduor has brought up, and it's always good to look at things from both perspectives, which is really a strength actually. However, we may not see it because the quality assurance bill is something good just on the wrapper. Probably the spirit behind it is what probably will bring in a lot of issues. My opinion was not to react on what Oduor has brought up, but I want just to raise on only 3 issues, which I kept on thinking as I was reading through the bill. One, it's speaking about the patient rights. What about the caretaker's right? What about the healthcare provider's right? It's not elaborate on what actually will be expected in return. Do we have rights? Because at some point we are on the other side is the patient, but now in most of the times will be the caregivers. What rights do we have? The other thing which caught me, it's on the fine, which has been brought out in terms of if you practice outside your scope. Look at it from this perspective. We have one individual from probably one body who may be having their own interest, who will be a member of a certain profession, being regulated also actually as a practitioner, and calling in shots on what the other people are supposed to practice. And if they go against that, then they'll be fined, and not some few coins. It's a slam of a whooping 10 million fine. Is that really warranted? And does practicing outside scope really bring in all that aspect? Because it's not bringing in issues to do with if you practice outside the scope and the patient suffers loss or anything of that. It's just practicing outside your scope with success, without success. Then you'll be fined at 10 million. I don't think whether that one is worth it. Finally, the third thing, which really looking at it on the quality, which the whole bill is about. But you realize that actually you cannot achieve quality without resources. And this bill will just be imposed to private practice. And remember, issue to do with quality will need a few coins here, a few coins there. Even without looking at the private practice, let's first focus on what happens in the public domain. We are having a big discussion whereby one national hospital is being given a budget which is more actually than a budget for the entire county. Health is devolved. So will this bill really cure whatever is looking at curing without bringing in resources? Actually, the bill could have even pinched in something to ring-fence health financing, especially probably bringing in issues to do with the Abuja Declaration and ensuring that if they are pro-patients, then they should have ring-fenced that. And probably we would have seen something to do with ensuring that there is enough funding, there is enough resources to run healthcare in this country. And as I went up, from my own perspective, I don't see anything new in this bill. I don't see probably the need of having this bill. We could have just brought in a policy or two, which does not need a whole new law, because everything which this bill is providing, it's been provided. And I'm telling you, and I will want to remove the sugar coat from the bill. This bill is coming to snatch away self-regulation. We have had countries coming in this benchmarking with us. We have had our colleagues in the East Africa benchmarking actually with regulation in Kenya. And now this bill is earmarked actually to come and steal that and snap that one. Because what will happen, it will be like, now we have been able to regulate facilities. Sure. Then now, what about just a small percentage of regulating the personnel? And that's where actually this bill is targeting. This bill has nothing to do with quality. And I want to assure you, my fellow colleagues, this bill is just a sugar coat. It's actually a smoke. The big fire will come. The big fire will come. Allow me to rest at that and allow the other colleagues to air their views. Thank you, thank you, thank you.
Thank you so much, Mutmut, for your contribution. And the question continues to come up, that are we really ready to allow this super regulator in the name of quality healthcare and patient safety authority to take over all these responsibilities without itself, not being checked? I would call them unchecked powers. Are we ready, and what is the way forward? Thank you. Let me have Chris Onditi and then Felix Ougo.
Thank you,
Chris
Mary,
Onditi,
and thank you.
Yes, welcome.
Hello, Mary, can you hear me?
Yes, now we can hear you. Go on ahead.
Thank you, Mary, for the opportunity, and thank you, the organizers. This has been a very candid and beautiful discussion. If it were not for the contributions of one Oduor Otieno, I would have just said, let's mobilize, and then we fill the holes, and then we just say reject. But I also want to say that sometimes it's good to listen to the other side of the coin. We initially had issues with the Health Service Commission that we felt would be a way of manipulating us, and it would be taken care of by the big brother. And we are also very skeptical about quality of healthcare authority or something of the sort, because we are not sure about how it will happen, despite a lot of clarity and a lot of explanation from our brother Oduor. Our fear has been our big brothers have always used every opportunity to. Hello? Can you hear me?
We
Yes,
can,
continue.
but you're breaking.
Is it better now?
Yes, you are audible.
Yeah, our biggest fear has been manipulative tactics of our big brothers. And so when this authority is formed, my questions to Oduor would be, and I'm happy that Mary has taken his contact so that he's included in part of our top leadership for his experience and further consultations. My concern would be, what will be the constitutionality and inclusivity of other cadres in this authority? Because then if it will be dominated by our bigger brothers, then we would not actually go there feeling safe. So the inclusivity would be our big concern. And then I want to ask our big brothers and our leadership, top leadership, to embrace our experts in this field so that we can have all-inclusive discussions around this thing. I personally, as a clinician and as a leader, I am honestly concerned about the quality of healthcare that some of our colleagues or our hospitals or our other cadres give in various spaces to our patients. You can go to some clinics or some private practice or even public places and you wonder what kind of quality service that they give to our population. So I am concerned about that. I'm also genuinely concerned about our members who practice in private places and they don't have the right to control the quality of services that they give. Some are actually truly deplorable, and some of our members get a lot of these share benefits out of doing nothing, yet people who give real services to people don't get some of these benefits. So I'm really concerned about this thing, and we would want to have a lot of expert inputs. But my biggest concern is inclusivity and the fear of our big brother wanting to take everything and to manipulate us. It is true that other countries admire us in terms of our regulatory bodies, and we want to stop at nothing to ensure that our regulatory bodies maintain their autonomy. But it is also good that we allow ourselves to listen from both sides of the coin so that we can also grow together as a team. Thank you so much. If it were not for Odur, I would have said mobilize and reject. But let's get more. Thank you.
Thank you so much, Onditi. We hear you loud and clear. Again, we're here to find common solutions as a team, and I believe we are going to be able to execute according to our plans. Felix?
Hello, can you hear me?
Go ahead.
Thank you so much. This is Felix Ouko. I'm a clinical officer. I get mad and I get sad when we refer to some people as big brother. These people deserve another name, and that is they are witches. A big brother is one who takes care of his brother. A big brother is one who appreciates the growth of his brother. A big brother is he who marvels when the younger brother is able to get self-autonomy. Younger brother is able to feed his family. But when you come here and tell us a big brother and is bringing you nyama choma that is laced with poison, and then you want to call that nyama choma to be sweet, no. This bill is nyama choma that has been laced with a poison, and I can see you people, you are going to eat this nyama choma and you are going to die. Why are you going to die? The moment the autonomy of practice, the independency, and the self-regulation is taken from COC, that will be the death of clinical medicine. That I can assure you. This is a well-calculated plan by two people, and you know them, the PS and the DG. And you are all aware, and I believe you people listened carefully when the DG said that clinical medicine should be stopped. And this is the first step to stop clinical medicine. I am mad and I am sad that even up to now, we are not agitated. If we can sit the way I can see people are not agitated, then I'm telling you this bill is going to pass, and this bill is going to be an act of parliament, and we will be left going to court left, right, and center. And you know very well that financially our muscles are weak. So what am I proposing? Number one, let's all of us come out on 24th and fill all the county halls and refuse and reject with very clear a memorandum that is coming from the leadership. This is not the time that people are going to sit back and say, oh, top leadership is going with it, what. Every clinical officer, the 33,000 clinical officers should throng those county halls. Then number two, we need to send a clear message to the nation, to the ministry, that we know exactly what Amoth and Oluga are planning, and their plan is to strangle clinical medicine. And number three, let's make sure that we have very clear, very robust, very vital legal minds that are going to help us to navigate this bill. Money has been set aside, members of parliament are going to be whipped, and this bill is going to pass. If we sleep, this bill is going to pass, and it will be to the detrimental of current clinical medicine and even the future clinical medicine. I rest my case.
Thank you, Felix. I will not say much. They have given you flowers with emojis. Allow me take the last one from Daniel, and then we give it back to the panelists who will bring forth their final comments, and then we bring in we bring back the host, Chair Peters, to be able to move away forward, and then we conclude so that we go beyond 10. So Daniel.
Good evening.
Daniel Teriot.
Yes, I hope you can hear me.
Good evening. Good evening. Welcome.
Yes, mine is
Loud.
just
Why?
okay. Mine is just word on what Felix has said, and I'll take you back to the history. History will always tell you something. There's always been a fight for clinical medicine, so I don't see anything new when it comes to hello. Yeah, I don't see anything new with this bill not being against the clinical officers. Remember, we've been fought on so many instances, including formation of union, NHIF, now SHA. For those that the pioneers of degree, we were also fought. We were told we cannot do surgeries, we cannot do anything. So, bottom line is, this bill is just, if it is not to kill clinical medicine, I don't know what else it's targeting. So we should be very careful in even entertaining the idea of this bill. Thank you.
Loud, clear, and quite straightforward. Thank you, Daniel. So we get comments based on members' contributions from the past. Let's start with our president, KCOE. Tole. Not coming. Let me bring Eric Ondieki.
Yes, Mary.
Oh, yes.
Hello. Can you hear me, Mary? I'm on transit and maybe you hear back now.
Please.
Can you hear me?
Yes, yes, we can.
Yes, I know there's background noise, but my fellow comments concerning this discussion on
Michael, please. Mandel, unmute Michael. Go on, Moses.
Yes, thank you. Thank you. My final submission on this discussion about the quality and patient safety here. I want to say that the Kenyan government doesn't back laws, but the problem is execution of those laws. Because we are all aware that even from the speakers who spoke, we know about the Patient Safety Act 2017, which is there. And I think what has been happening is that execution has been a challenge. So this bill doesn't seem to fill any gap. What I'm seeing from this bill is basically to ensure that other professions are not having autonomy. And if that happens, then we are one of the cadres that will be mostly affected. So let's come out in large numbers. Let's share our concerns. Let's ensure that this bill does not go through. Otherwise, if you're talking about patient safety, it's not just about the facilities. It is not just about the human resource. There are a lot of components which should be sorted to ensure that there is safety and its quality and our patient safety. Thank you. Back to you.
Thank you so much, Mosa. You've heard it. Please come be content. Participate, contribute. Don't shy away from speaking about this. Let's hear from Ashira.
Yes, I'll say this that anyone supporting the bill is the enemy of the profession. The enemy of a clinical officer is the enemy of a PHO, is the enemy of a lab technology, is the enemy of KUNAD. And all of us, we need to agree from today going forward that come on 24th, we need to draft a memorandum as quickly as possible, saying reject, 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 and saying, and that note will come out very clearly even to Parliament. We need to communicate that note to Nikal. All the officers, any officer of authority in this country must know that we are in total rejection. We are saying no to that bill, and all of our members, I think as public officers, we are going to mobilize all our colleagues in the other country and even outside the country to say no to that bill. And anybody supporting, we are going to label as the enemy of the profession as well as the health sector in this country, because you'll be participating in killing healthcare in this country. So we expect all of us to join hands. Please, let's not accept. They always say, if something is good, if 10% of something is good and then 80% is bad, then that thing is bad. Don't even accept the 10%. Don't even think of saying, oh, I need 20% of that thing is good. Like I've had one of our colleagues here saying that, you know what, no, blah, blah, blah. No, let's go to the court thing. Kitu ikiwa mbaya ni mbaya, and we must say no. Na kama ni mbaya, kama ni mzuri, kwa nini wanataka wanatulazimishia? Kama uko na msichana mrembo, you don't need to use a lot of words to talk him, to convince him akuwe bibi yako. You will use a little amount of words, a little of words to say, I need you and I want to marry you. You don't need to use a lot of words. Oh, unaandika text book mzima at wacha nikuoe. Hapana. This thing is bad, and from the word go, the way it's being rushed to our throat. We need to look, we have an equal time and look at it and say no to the bill. As public health, we are saying no to the bill. I think everybody, we need to sign that memorandum. Like that day of 24th, all of us must come on board and say no. Otherwise, I want to appreciate KUCO for leading the space. I think as public health officers, we're also going to follow suit. And I believe also the lab are going to do the same, and nutritioning and the same. And I was thinking this, we need also to sponsor a hashtag. Like, for example, we need to go now to the mainstream media, social media pages, the same way we rejected the finance bill. The same energy we used to reject the finance bill last year. The same energy now we ourselves, the workers, we need to use and say no to this so that we can actually stop operation and to muzzle our profession. So thank you so much. I think we are ready.
Thank you so much, bro. A spade is a spade. It's not a big spoon. Let us hear from Odipo Nicholas.
Thank you very much, Mary Boniface. I have a few comments to make. We have all agreed that this bill is bad. And if the drafters of this bill thought that it was good, they would have involved all the regulators that the acts are going to be amended by this bill. Number two, as we prepare a memorandum, we also need to exploit other ways and means of rejecting this bill. We had already talked as a medical laboratory, and we were looking at the option of stopping the public participation. And we thought that we could go the court way, of which we are still on it, and we believe we'll be able to get those orders to stop the public participation, because this bill, or the proposers of this bill, have their hidden interest. And that interest is not about quality. We have all agreed that. So sometimes in this country, public participation are just for like a legal bridge. It is done for formality to meet the requirements of the Constitution, so that when one wants to challenge a bill on that front, then they'll say that we did public participation. You all remember what happened to the Finance Bill 2024, in which Kenyans gave out their memoranda, and none of the memoranda were factored in or were considered. So as we look into the public participation, we must also have other plans, so that in case our views are not taken into consideration, we have another option to stop this bill. Otherwise, if we let it go to public participation, and with the interest that that is there, those memorandum that we are going to write might not see the light of the day. I'm also thinking of we have a presser next week, so that we can state our position from the word go. We have to tell these people that we are not ready, and we will never be ready. I also want to encourage us that let us be united, because this thing is affecting us, and it is something that is aimed at managing the healthcare professionals by these witches, as our speakers named them. It is selfishness from our colleagues, and it is time, Chairman Washira and Gibore, it is time we come out very strongly and tell these people that we are also important in healthcare. This issue of seeing us like we are children of lesser God, or rather we have not gone to school and there's nothing we know, and we cannot add value to the healthcare system of Kenya, it has to stop. Because while we are struggling to offer services to our citizens, majority of these people who want to manage us, they're in their private practice, collecting huge amounts of money, at the same time drawing salaries from the counties and the national government, which is quite unethical. If they wanted to come up with this quality healthcare bill and patient safety, they would have started by themselves. Because all these things, the unethical behavior, has only been reported on them. In these other cadres, we've never had anybody who has done unethical behavior or a professional misconduct And if they are so minimal as compared to our brothers, the medical doctors. So this issue of managing us must stop, and we must come out very strongly and oppose any further attempt to manage us. Let everybody practice what they went to school to do. You should not put your nose in other professionals, and that you are now admiring the other professionals, what they do. You want to manage them, yet you also have your own profession. So as I conclude, let us have these suggestions and ensure that we stop this bill altogether. Thank you very much. I submit.
Thank you. And moderator, can the oldest man on this forum finalize? Unajua kabla sijalala niseme mwisho.
Please.
Unajua mimi ni mzee, wacha nimalize alafu nilale.
Sawa Duba, go ahead.
Oh, thank you so much. I think the speaker just was talk a lot of sense. We must have a plan B. We have all agreed that this is not a bill that really is not for even the health, not about the quality of health to the patient or the rate of health to the patient. It's about selfishness. It's about people trying to look for employment. And as I said earlier on, we have multidisciplinary accrediting institutions. And there's no gap at all. Watu wanatafuta kazi, and then those people can even, they are owners of the private practice. We know them. And so the laws that is existing has no gap at all. Authority is being created to create employment, to really make regulatory boards non-existential, and to take away from what people have fought for. And clinical officers regulatory board, public health officers regulatory boards, they are the most competent to regulate their practice and their profession. Plan B must be there. If we are going to court, we must enjoin. I'm the chair of Kenya Health Professional Society, and I believe all our members are here. We must enjoin. If anybody is going to court, we must enjoin all of us as 18, 19 health professionals, including mortuary attendants. This profession cannot be entitlement of one cadre. Cannot be. And I believe even the other cadres are not for it. It's just about selfishness of some few individuals, and we cannot take it. And for that purpose, in conclusion, because mimi ni mzee nasema hata kulala, if we are getting plan B, tukienda kotini, sisi wote tuna sign. Kama ni kuenda county, all 28, all professionals should be there. I think the way forward is very important. We have expressed, we are together, and let's not be separated anywhere along the way. Let's not be manipulated. And finally, I want to thank KUCO for the initiative, for bringing us together and even taking us through the bill. I'm sure not everybody have read, but I think that's wonderful initiative, and I really say thank you and thank you and thank you.
Thank you so much, Duba. Let's hear from Lillian.
Thank you, Mary. I was almost trying to say I'm also in that generation who needs to rest, but we thank God. Thank God for the opportunity that you have provided. So I've listened to the insights, and it's very clear that this is not just a bill, it's a bill that is meant to frustrate people and to make it almost impossible for us to act both independently and autonomously as healthcare workers, as healthcare professionals. We have experienced a lot of domination, one cadre dominance when it comes to how matters health are run in the country. And I think moving forward, we also need to have a strategy, as the chair for NUMBLO has said. We need to have a backup plan, maybe an angle of coming at it, because as you can see, the title or the highlight that is actually being used for this bill is all about patient protection. And in Kenya, there has been cases whereby patients have been claiming that they are not getting quality care. They have been claiming that they are not getting what they deserve as Kenyans. This can be used as an angle of manipulating majority of us. And we know Kenyans, we are emotional and reactive people, and we can fall prey to that. I've also listened to one colleague who was saying that we need to also understand and highlight the strengths or the goodness of the bill. Now, as someone highlighted when we were starting, they say that the country has enough regulation and enough acts. So instead of coming up with new, of course, we can also come up with a patient protection bill or law or act that is actually meant to protect the Kenyans. But clearly from the content of this bill, there's nothing even about the Kenyan. It's all about controlling the facilities, controlling the cadres, controlling the billings and all that. So we need to be a bit objective and also look at the angles, the different angles that we can tackle this or we can address this. And yeah, maybe moving forward, we need to maintain unity, because we cannot be seen as we are fighting one cadre. Again, we look like hatujielewi, unaona? So I think that's also an angle we need to explore. And thank you so much for holding this session, Kuko. We appreciate it.
Thank you so much. And we also appreciate you. Majority times like this, we need teamwork, and you're here so that we work together as a team. SG you here? SG If Chebi is not with us, Ondieki, are you back? Eric Ondieki?
Thank you, colleagues. I followed the conversations and I must appreciate all our contributions. Just like you said, read the act, understand, put your facts down, even if you're going to present that memorandum, read it, understand it, internalize. From 23rd to 27th, let's ensure we are at all those 290 constituencies where they're collecting views. And something that I need to say here is that we need to go out of the box and think, just like you've been thinking. Government is also crafty. It will plant a few patients to come and sign those forms in support of their bill. Don't forget about that. So also we must be very cognizant and probably carry along my few friends here and there to so we also have to look at that angle. We must rally support from our relatives, our friends who are not clinicians, to also come and support our angle if we want to survive. Otherwise, if we go the way we are going, we'll all perish. Government is crafty, and you've seen what they do with public participation. They can even sit down under the tree and fill all the forms. So let's be there, get the attendance sheet, see what happens, collect evidence from source. So if you want to go to court, then we have evidence from source. That's all I have to say, but thank you so much and have a good night.
Thank you so much, Ondieki. I hope we all had that clarion call. Please do something about it. And then I would like George to conclude for us, George Gibore. Katibu George Gibore, are you here? I think he cannot hear us, so he dropped. Maybe someone can help confirm. I would want to bring back my co-moderator, Philomen Mayek. Madam Treasurer, can you hear me? Looks like she's also not with us. Then if that is the case, I would want to bring back the host, Peterson Washira, to move away forward, and then we close at that because our time is here. Peterson Washira.
Yes, Mary, can you hear me? Can you hear me?
Yes, Chairman, we can hear you.
Very well. I want to thank everybody who has participated that there were very valuable input. And in summary, I think I would like to say this so that the message is not lost. That first of all, even before you look at the details, one of the reasons as to why we are having reservations with the bill is that we do not understand why we needed to replicate what was in other acts of parliament to just consolidate them into one bill. That is number one. Number two, we also don't understand why we could not make the health
Chairman, you are breaking. Chairman, you are breaking.
Okay.
We can't hear you.
Are you getting?
Yes, yes.
Very well. So what I'm said first is that even before you look at the details of the bill, one fails to understand why we would need another bill to talk about quality. Quality, it is not that there hasn't been quality. It is not that we have not been regulating quality. It is only that it has been in different bills and given to different institutions to be able to ensure that quality. Take the responsibility from 5 regulatory bodies to look at the quality of the facilities and reduce it to one authority. Is that going to help in terms of efficiency of ensuring quality, or is it backtracking? Number two, please confirm you can still hear me.
Yes, yes.
Yes, number two. Yes. And it's not that our problem is not even the doctors per se. But when you also take the responsibility to make or to develop the scopes of practice from regulatory bodies, which are composed of educators, are composed of practicing clinicians or health workers, regulators, people who have knowledge in many other fields, and you take that to one government officer. Are we improving the quality? Are we reducing the quality? So what I think we are saying is that number one, there is no need to replicate laws. We cannot have a law for everything that we think of. When we think about quality and patient safety, we make a law that is named quality and patient safety. When we have a health act, we should have a health act that is comprehensive enough to carry everything that we think that was not carried within the others. So, and of course, we talked about the issue of quality assurance. Our biggest problem has not been the regulatory bodies themselves being the ones registering and licensing and accrediting only. It has been that it is one body that does everything, and there is nobody who comes to verify before SHA can take up the facilities. But instead of establishing a mechanism where we can be able to verify, we are just retaining the same thing. We are only transferring the responsibility from a single body doing everything to another single body doing everything. So we're still going to have a problem where you find a level 2 given the status of a level 3. And if you look at this combined, of course, with the fact that the court had already interpreted that the body responsible for quality of health in Kenya is KUCOEngage, then it means we really didn't need whatever has been added, the few things that have been introduced, which are good things, which have been introduced in this act. These are things that only needed an amendment of the Health Act, so that once they amend the Health Act, then it becomes comprehensive. But do you know the reason as to why they don't want to amend the Health Act? It is because amendment of the Health Act must then incorporate the judgment in the case against discrimination established in the Health Act, and that means the positions that have been reserved for certain professionals, then those positions, it will have to be amended so that then it can be occupied by any other healthcare worker. And that is why people are avoiding the Health Act. But I think it is incumbent upon us, now that we know this, now that we have professions to protect, now that we have health of a country to protect, because we as the health workers, we as the associations and the unions, I think we are left as the only institutions which can see that honestly, we are after better health for our people. The people who have been tasked with that role, most of them are just making special purpose vehicles so that they can do business with them. And so I think going forward, ourselves as the leaders, we will be sitting together. We will be coming together from Monday to draft a memorandum, to look at it critically, to engage lawyers, and to draft memorandum so that then we can share and we can have our people to go across the country. And also the plan B. Of course, what we will need to do if they don't listen to us, and even what we will need to do if they go ahead, pass it, and it's assented. Because this is a democratic country, and they can try as much as they can, but they cannot force it upon us. We will fight until we ensure that we have a legislation that guides us to a better path towards better health for Kenyans. Thank you. I think you can respond in the chat box and indicate what you think about the bill, because today was really about to understand about it. Going forward, we are going to have many other platforms, including X Spaces, to discuss about now the details of the bill, why we are rejecting or agreeing. Today, we just wanted people to really understand what is before us. But from next week, we will be out there discussing the bill and saying exactly, in a very objective manner, exactly why we think things should be done in the way that we will be able to guide through the memorandum. So please leave your comment, and I think we can close at this juncture because it's already 10. Have a good evening, have a good weekend, and thanks for your participation. Thank you. And back to the moderators.
Thank you, Chair. I think you've summarized it well, and I don't think we need to keep engaging further. I think that will be a good point to close it up. Let's have a quick prayer. Heavenly Father, we thank you for the session that we've just had. We thank you for your continued guidance and protection. Dear Lord, we have a lot of work ahead of us, and we pray that, Father, as we go to work on this, that you're going to be with us, that you're going to be our guidance, and that you're going to help us pick the best way forward for the healthcare profession. Dear Lord, bless our night and be with us. In Jesus' name we pray and believe. Amen. Good night, people. Let's keep engaging. See you soon in the next KUCOEngage session, which is going to be next week on Wednesday. Bye-bye.
Bye-bye.